This month on Decibel, our topic is healthcare inequities. We're going to be talking to people on the front lines today from various perspectives in the healthcare field. So first thing I want to do is have each of you introduce yourselves.
And I'm Dave Flieger. I'm a colorectal surgeon here in Austin, and I'm president of the Texas Medical Association.
I'm Minnie Callon. I'm vice dean at the new Dell Medical School at the University of Texas at Austin, and I direct a program called Factor Health.
I'm Regina Rogoff. I'm CEO of People's Community Clinic.
And my name is William Buster. I'm the Executive Vice President for Community Investments for the St. David's Foundation.
Well, thank you all for sharing your viewpoints and your vision when it comes to healthcare inequities in our state and in our community. The first question really is, paint a picture for everyone who's not in the healthcare field about kind of where we are right now, because I know that Texas has more uninsured people than any place else in the country, any other state in the country. So first of all, let's kind of set the stage. Where do you think we are with healthcare when it comes to some of these inequities in our state?
We're last. Yeah. We're 51st or 50th, depending on whether you count the District of Columbia or not. So we have, 17.7% uninsured, 5 million Texans without insurance, which makes us the worst by far. And that's a problem, especially in a state that's as prosperous as we are.
And I'd say insurance, having insurance is not even table stakes, it's sort of stepping stool stakes. So we're just talking right now about very base level pieces, i.e. having insurance in place. I think the next question is really, what can we do once we have insurance and the gaps that people have, whether they have insurance or not, which is, I think, what we'll chat about. Mm-hmm.
Just think about it from a family's perspective. If you don't have insurance, and the conversation that we often don't have is, so what are those people doing that actually need access to care and are not going? And so we probably have even more sicker people than we even know about, or people living on the verge of being very sick because they're afraid. They're afraid of the bills that come with going to seek out medical care.
And that has long-term implications.
Yes. Well, and in addition to everything that's been said about insurance as the stepping stool to get into the system, there are many people for whom the real issues aren't about health care, it's about health. What are the social determinants? What are the conditions in which they live, play, work that impact their well-being and their health? And in Texas, we have a huge need to address those conditions, whether it's hunger or violence. There are so many day-to-day life issues that impact people's wellness.
What about the nonprofits that are filling this kind of gap, this healthcare gap? What are some of the nonprofits doing that you all support at the St. David's Foundation? How are they helping?
We support almost every clinic in this community in the Central Texas area, and so we are supporting organizations like the People's Community Clinic and other clinics that are actually seeing the folks who don't have access to insurance, who don't have access to primary care physicians at the ready. And so the folks that we're supporting and in partnership with are seeing those folks that often fall through the cracks. And we view ourselves as that catch-all because we want to see this community be the healthiest community in the world. We can't be if everybody can't be healthy. We're quite a healthy community if you take the percentages, but there are people inside of this community that don't have access to the things that many of us have access to. And so we partner with those organizations, whether it's a clinic, whether it's a social service organization, that are going to provide the services that these people need to be healthy.
And I would like to dispel any idea that people who come to clinics like People's, which is considered something called a federally qualified health center, has a special designation, are getting somehow substandard services.
Yes.
The quality of care that someone gets at our clinic, I would put up against any medical practice in the community or the state, the nation. We are actually ranked among the top 10% in the whole country for federally qualified health centers. So our patients get really good care, on top of which we work very hard with foundations and donors to offer wraparound services that most private practitioners aren't able to provide. All of that said, the need is still so much larger than any one clinic. We have 17,000 patients. That's a small piece of the total population of need, which is closer to 250,000 people. Now, we're not the only clinic system addressing that, but there's a huge amount of need. And so being able to offer really high quality to a segment of that is wonderful, but really being able to offer something to everybody is also extremely important.
No, I'd agree with that completely. Our federally qualified health clinics provide excellent care, as do hospitals, and certainly our safety net hospitals like Dell Medical provide excellent care. The problem is that probably the majority of care for those who are uninsured or underinsured in the city occurs in our emergency rooms. And it occurs when they finally get to such a point that they're sick, can't stay at home, can't work, they finally come to the hospital. And of course, the disease process, whatever that is too far along to really be efficient as far as its management is concerned. It costs us much more to take care of those patients when they have, I do a lot of cancer surgery when they have an advanced cancer, much bigger deal than if I were to do a colonoscopy and take out their polyp and never have that happen. And that happens literally hundreds of times a day in the city of Austin.
So there's some real long-term implications for all of us. And I know, Minnie, you are there training the doctors of tomorrow. Tell me about your work and how it fits into this.
Yeah, I'll build on what my colleagues have said, really emphasizing, taking it a step up, that our system is flawed. So this is not a simple sort of linear conversation about can we just get more of what I get. Yes, a little bit more of what I get would be great, but actually probably the most of what you'd want from what I get is the flexibility that I have and the resources that I have because I have a particular kind of income. That's, coming back to Regina's point, issues around the sort of socioeconomic drivers of health. But the system that I face is broken. But that broken system has a disparate impact, much more of an impact on people that have fewer resources. So it behooves us to step up a notch and, to your point, to really think about why are people showing up at the emergency room. I chose to go to the emergency room. It was a flawed decision. Once I was in the emergency room, they took me around. They did tests that were not necessary, frankly. I got a bill for it at the end that I should not have gotten. Take that and now put it to the case of someone who has much fewer resources than me. The pressure I felt for not taking time off work was still kind of I would call it a privileged pressure, because I still could take time off work because of the way I earn my pay. For someone who's hourly, that pressure is now amplified, right? And so everything that I felt 100 times worse for someone with fewer resources. So I think the Texas example, for me, it definitely is the case. As I said, we're number one at having the most uninsured, not the number one that I'd want for Texas. We're number one at being the most expensive system in the world, not the number one I'd want for the US. But in Texas, is there a way that we can flip it around? The pricing issues are so complicated, the systemic problems are so complicated that it opens up a space to do something completely different. And I believe that it is in the culture of Texas to say, well, hey, if there's something big, let's do it. And so I would say, is there a way to look at this gap and turn it on its head and sort of kickstart a new kind of a solution?
So what would it take to get to what you're describing? Because right now, we're one of, 14 states that's decided not to expand Medicaid. And we're dealing with a lot of uninsured children. What would it take? It seems like a huge mountain to climb to get to do what you're talking about. Am I correct?
Well, the one thing I just want to correct is on children. Children are actually one of the better insured groups in general. It doesn't mean that they're on gaps because of Medicaid and CHIP, et cetera. I'm not saying it's perfect. I think we can be innovative in how we manage those Medicaid contracts, put incentives in that really emphasize kids' health. So for example, even though Medicaid and CHIP, you would think insurance companies stick longer with kids, that they'd be more interested in long-term solutions. The reality is, even there, still, everyone is looking for solutions within 2 years. So I think the state has an opportunity to create an incentive structure with kids that are insured, which is the majority of our kids, where we actually start incentivizing solutions that take a little bit longer to play out. But if we can get that to happen, we already have the insurance for kids, so there's a great opportunity area. For adults is where we start having some real challenges without insurance.
Well, so your question is it's a big lift, and I think it's essentially a lift that I'm not sure the state can do without pulling down the federal dollars. And whether that means expansion or whether that means some other type of a waiver that allows Texas to bring down those dollars. I mean, our federally qualified clinics do so well because they pull down federal dollars, okay? Our other clinics, our doctors in rural areas, they don't have that advantage to be able to put those clinics together. They get paid less every year by Medicare and Medicaid than they did the year before, and they have for the last 20 years. It doesn't keep up with inflation, and yet the 80% of rural Texas is Medicare and Medicaid. So we have to find some way, and essentially, ultimately, the lift is bringing down the dollars from Washington, because those are our tax dollars that we paid, and now they go to expansion in California or New York or wherever else.
As a state, we've been penny wise and pound foolish. We haven't invested where we could have, and we've let billions of dollars slip through our fingers. But I don't think that even if we drew down those dollars, which I heartily endorse, I completely agree should have happened long ago. We have basically an incredibly disjointed system where sometimes it's the body part, not the person, that is insured. So if you have breast cancer, there's some special insurance that covers the breast, but there isn't special insurance that covers colon cancer or pancreatic cancer or other cancers. I mean, if you are lucky enough to get the particular disease, the disease of the month that has the coverage, I mean, it is an inhuman, irrational, inexplainable system. So therefore, then we say, well, we need navigators, because we've created such a bad system that people don't know what to do with it, that now we have to create a whole new job description, a whole new group of people who will help you navigate this incomprehensible system. One of the reasons that drives people to the emergency room, toothaches. Toothaches. Using up the huge.
They're not going to your dental clinic.
But those dental clinics are for children. The St. David's. For adults who have
there is no coverage.
Texas has no program that covers adults for health care, even just plain health care, certainly nothing that covers them for dental services. And the fact that our emergency rooms have people waiting in the emergency room because they have a toothache.
I want to talk about this also from the nonprofit situation, because these folks are on the front lines every day. Have you seen the need expand over the last, 4 to 5 years? As we see more people uninsured, or what's happening at the ground level with these nonprofits that are dealing with the elderly, that are dealing with hunger, that are dealing with people who lack insurance?
Yeah, that's an interesting question. What we're hearing is that there is more need because of the cost of living. So what we're seeing here in Central Texas is, as people are being priced out of living in the city core, they're needing to move out to places that are more accessible, at least for their income. But in those places that they're moving, going Caldwell County, Hayes County, Bastrop County, Williamson County, parts of those counties, they don't have the services that are here. And so the need is skyrocketing in certain parts of our community. And where the services are, we're getting less people. There are less people living in the core. But I want to just make sure I pull us back to a very important point. And Regina's right. We need more of focusing on. But there's already data out there that says if a state has expanded, if they've drawn down more federal dollars, we're beginning to see health outcomes improve because there's more access to insurance. And so, if we really want to be about saving money, I think pulling down the resources that we can to expand for folks. We can call it whatever we want to call it, but we have to be intentional, because the data is showing that people are getting healthier if they have access to insurance in this country.
But wouldn't it be great if we created a competitive system based on results? And we drew down these dollars, but created our very own Texas system, where not only did we draw them down, we also established for the country a way where we could change and actually look at Group A versus Group B, trying to solve the same problem, and who did better, and what can we learn from each other.
So what do you think is important to this discussion that we haven't covered today?
So I don't think we've actually touched on a very important issue that is referred to as institutional racism. It's the subconscious, the unconscious, the aspect of what people experience when racism exists but isn't acknowledged and isn't dealt with. And sometimes it manifests in terms of the actual physical health of the person who's on the receiving end, the person of color. We have a high incidence of maternal and mortality and infant mortality in this state, much higher than a first world country should have. I mean, it is a serious problem. And I think that it is intimately tied to the stresses that women experience who are of color, but in an environment that is largely not.
So I'm going to let you two have the last word on things that we haven't talked about that you think are really important to this discussion. Dave?
Well, I'd say from a physician standpoint, and from my standpoint personally, is that this is a personal issue for our patients. Okay, the child who has developmental problems that go undiagnosed, the child with asthma, the child with diabetes, they don't do well in school, they don't go to, they ultimately don't become good, productive members of our society. The other personal part of this is that as part of this conversation, we purposely tried to figure out some of the issues that are there, but I think it's important to know that the doctors and the nurses and the therapists and the counselors and the hospitals and the clinics, they have the patient's best interest at heart. I mean, that's what these people are dedicating their lives to, is to try to make our patients better, try to keep them healthy. And I think that's probably the most important point.
There's not much I can add. I think the only thing that I would say that builds upon what everyone has said about what we've not talked about is the connection between, understanding the connection between that you have providers who they've dedicated their lives to doing better and to serving people, but they are human. And so the pieces around that are blind to us, the cultural nuances and the things that we don't often think about when we're serving others that don't actually come from our background, are very prevalent in the healthcare system. And so as you are human, you are a provider, you want to provide the best care, know that you don't know all the things that you need to know about the populations that you're serving, and ask yourself the questions when people are not asking you questions as a provider. Oftentimes I've heard physician friends of mine, it's like, people don't ask me enough questions. Well, maybe because they're scared of you, And so I think being mindful that there is two sides of the system, the folks who really care about serving the folks, and the folks that really care about how they are served. And I think we have lots of room to kind of work towards the middle in that.
William, Regina, Minnie, Dave, thank you so much for sharing your nuanced perspective on this issue. And I think that folks watching today, at least I hope they'd come away with a better understanding of where we are as a community and a state, and perhaps where we might improve. So thank you all, and thank you for giving us a little bit of your time today as well.